Hey, everybody. Welcome back to Pulm Peeps. Thanks for tuning in and listening today. Make sure to like and subscribe wherever you're listening. Sign on to our website and follow us on any social media that you're still using for medical things, which is rapidly decreasing. But we're excited to be back with another case today and to dive into some interesting and fun medical issues. Christina, you are recording live from the hospital, tucked away in a patient room corner, an unoccupied patient room. But so this is a little bit of a rebel podcasting. I love it.
I know, Furf. So glad to see you, though. I know this is one of our favorite types of episodes to do with our fellows' case files, because it really gives us the opportunity to highlight such amazing educators across the country, as well as highlight some fellowship programs as we go into fellowship recruitment season here in just a few weeks. So very excited today. We're going to be joined by two fantastic guests from the University of Kansas Medical Center. And I'd like to introduce our first guest, who's Dr. Vishwajit Hegde, who is currently a second-year Pulmonary and Critical Care Medicine Fellow at the University of Kansas Medical Center. He completed his IM residency at University of Kansas as well. So staying on for a bit, may or may not be a lifer, Vish, but excited for you. Thank you for reaching out to Dave and I and trying to present this interesting case, and welcome to Pulm Peeps.
Yeah, I'm a longtime fan and a longtime listener of the show, and I'm beyond thrilled to be here.
We're excited to have you. We're also very lucky to be joined by Dr. Sahil Pandya. Sahil is an associate professor of medicine and the program director of the PCCM fellowship at KU. One of my best friends did their training at KUMC. He's going to be very excited that we're virtually visiting you guys. Thank you so much for making the time and coming on the show, Sahil.
Thank you both for hosting us today. It really is an honor. And like Vish, I am also a longtime listener and a huge supporter of your podcast. And I think you guys really create a nice environment of inquiry and curiosity, and it really aligns with our values here at the University of Kansas. And also, like in this world where life is always on the go, learning on the go is such a really nice complementary exercise. So thanks for all the hard work that you do. I know it's not easy, but we know that we all benefit from it. And we're excited to learn from you guys today as well.
Oh, we appreciate it. Flattery will get you everywhere. So
I've learned well.
Very good. And as a reminder, before we dive into our case, this podcast is not meant to be used for specific medical advice, but rather for medical education. The views we express today may or may not reflect the opinions or policies of our respective employers. And the case we present today will be HIPAA compliant, and some details may have been changed to protect the privacy of our patient.
Awesome. Thanks so much, Furf. Well, very excited to go ahead and go into the case. And I'm so sorry about that. Let me get back on track. Thank you so much, David. Really excited to get into the case. And Vish, I know you brought us a really interesting case that highlights a few things today that we'll go over, but also the importance of diagnostic flexibility in pulmonary and critical care medicine. And I'm hoping that you can start by telling listeners today how your patient first presented.
Absolutely. So I have a 26-year-old immigrant from Southwest India who presented with a 6-month history of progressive cough and shortness of breath. He had no past medical history and had immigrated to the United States 2 years prior. He was initially evaluated in the ER, where imaging revealed bilateral pulmonary nodules. These were quite impressive, so much so that the ER picked up the phone and the first person that they called was infectious disease. They ordered a set of sputum cultures as well as a quantiferon gold. The sputum spares were negative and the quantiferon gold was indeterminate. The plan initially at that admission was to pursue a bronchoscopy. However, the patient was very reluctant. So given the high pretest probability of tuberculosis given his background, he was empirically started on antituberculous therapy for presumed malaria TB. However, his symptoms worsened and he returns 2 weeks later to the emergency department after a generalized tonic-clonic seizure.
Awesome. Thank you. A lot, even in this short presentation that we have to process here. And so many things in pearls that I want to bring up. One of my former mentors from fellowship would always point out that the original name of AJRCCM, one of our main pulmonary critical care journals, was tuberculosis. And that while tuberculosis is often managed by infectious disease now, especially in the United States, this is really a pulmonary problem and something we should be very familiar with. So that's very interesting. And then we also have a patient now who's undergoing therapy and comes in with a new generalized tonic-clonic seizure. So that's its own thought process, its own diagnostic schema, someone coming in with a new seizure. So we have a young man, progressive respiratory systems, nodular lung disease, maybe a sort of miliary pattern was referenced on empiric treatment for TB who has new seizures. So that problem representation is 26-year-old, as far as we know, immunocompetent man, but with diffuse pulmonary nodules. So we're wondering about that immunocompetency and new neurologic symptoms. Certainly, somebody who has tuberculosis, we know tuberculosis can be in any compartment in the body, right? And so if we're empirically treating for pulmonary tuberculosis or miliary, which we really think of as being spread through the blood vessels at this point, then we're thinking about disseminated TB. And 1, 2, and 3, I'm thinking about what the CNS space is carrying. The patient's also on new medications. So anytime someone has seizures and they're on new medications, I always want to think about the medication effects. We're also thinking about disseminated or nodular appearance of lung disease, and we don't have anything confirming this. We're doing empiric management. So is there a different diagnosis that could be responsible for both CNS and pulmonary findings? Fungal infections. I'll always remember, I think I probably got the question wrong, but on my pulmonary boards, there was a question that was about a respiratory disease, and all it was a CNS scan, and it was a nocardia that you were supposed to recognize. The nocardia can do this very commonly, and so even to the point that it made it to pulmonary board. And then non-infectious malignancy, sarcoidosis, other inflammatory diseases that we know can be in the lungs and the brain. And then finally, we can't forget about just serendipity, common things being common. Did this person have a pulmonary process? And then they're also somebody who drinks alcohol and they're coming in with alcohol withdrawal seizures, and they have some other happening. So we're going to look for a simple unifying explanation, but we're also going to keep our differential broad. Christina, anything to add? Any other thoughts?
Yeah, thanks so much for doing that. I think such a kind of a broad differential just on some preliminary information that Vish has shared with us. But I think I'm hoping this is going to be a really great case where it's so tempting to say, yes, the imaging fits with this, given the history, it has to be TB. But I really think that we have to think about the whole patient and not check our cognitive biases, avoid premature closure. I know we've talked about that before in some of our other episodes. And as Vish was talking about the lung findings as well, it just reminded me about one of our earlier episodes that we did with Emily Friedenmacher with miliary opacities, and that actually ended up being disseminated histo. So I'm actually important, and we want to hear a little bit more relevant history, any exposures, some exam findings, Vish. So I'm hoping that you can share that with us now.
Absolutely. This patient's past medical history was pretty unremarkable, except for his recent presumed TB diagnosis. He reported no allergies to us, and he was recently started on the RIPE regimen consisting of rifampin, isoniazid, pyrazinamide, ethambutol, and as well as some pyridoxine supplementation. This patient was a non-smoker. He drank alcohol only socially and denied any illicit drug use. He lived notably in Ohio for a very brief time before he returned to the Midwest. His vitals were a temperature of 98, a heart rate of 92, a blood pressure of 120/75, a respiratory rate of 24, and an oxygen saturation of 96% on 2 liters of nasal cannula. On exam, he was alert and oriented, and we did not have any gross neurological deficits that were noted. His pulmonary exam showed a normal work of breathing, and I was able to appreciate some scattered RALs, but apart from that was, once again, pretty unremarkable. Otherwise, his musculoskeletal exam showed point tenderness on his lower back, but apart from that, the rest of the exam was essentially normal.
Awesome. Thank you for summarizing that. So we have a lot of pertinent negatives. We do have some things that we want to think about for social exposures. I was going to add a couple other thoughts here that as you walk us through it, certainly point tenderness in the lower back on someone you're worried about TB makes us worry about whether or not we have dissemination of bones. I will also say, while it definitely could be right to empirically treat with TB, I'm not commenting on that, the decision that was made prior at all. We generally make every effort to confirm TB, right, as we're treating it. And this is both because it's important diagnosis to confirm, but also we want to get resistance testing, right? There are multiple reasons why we want to be able to grow this, and we should be able to from a biopsy or a sample from somewhere. And then finally, the last thing I would just add before we go forward too is with someone who comes in with new generalized tonic-clonic seizures, and then by the time you're seeing them, the neuroexam's normal, they're awake. We always just have to remember that convulsive syncope is often confused for seizures. So just because it looked like someone was shaking doesn't mean that it was necessarily a seizure. Now, in this case, if it's witnessed, then you often can take it to the bank, but just always keep that in mind. Sahil, I wanted to turn to you though. Now we've had an exam, we've gotten a little more history. Curious if there are other things that you're thinking about to add on to my rudimentary differential, and then additionally what you would be thinking about for the first steps in the diagnostic workup.
Absolutely. So I think this is a great foundational piece that we can build on. And so for me, as I think about patients that really present with pulmonary complaints, I really find myself using a combination of both subjective complaints and objective information, really to think about it in a schema of pretest probability for a likely diagnosis. And that really guides what tasks I'm going to order, if the risks outweigh the benefits, and so that we can really be high yield for our patient and serving them well. So from the very start, I really found several of these aspects of the case atypical. And I really make notes of these in my mental schema evaluation. So first of all, this is a young patient who really presented with a subacute onset of almost 6 months of shortness of breath. I always make the point for all learners and trainees, and also for myself, that timing of pulmonary evolution is so important in narrowing your differential. And without even having any imaging, I can really assume with a reasonable amount of certainty that there's probably a reasonable amount of parenchymal burden to have warranted empiric anti-TB burden to begin with. So already a really atypical story. I would think that an acute bacterial or viral process would generally not be present with such a prolonged prodrome. And so a strong parenchymal burden plus a bacterial superinfection, for example, would really have an accelerated course. And it seems like that's not what was going on in this case. Also, the patient provides the history that the symptoms are worsening. And this was despite what we would assume to be adequate treatment and escalating with seizure history. So hearing these complaints, my mental model thinks about combined pulmonary and CNS infections that you've already alluded to, Dave. And that includes things like nocardia, endocarditis with embolic events, fungal infections like disseminated crypto, disseminated blasto, maybe some parasitic infection, but also thinking about non-infectious causes like autoimmune disease and malignancy. TB therapy in the United States is generally pretty effective unless you're running into really drug-resistant cases. So my first thought really jumps in questioning and verifying the diagnosis, which would include verifying TB-based serologies, following evolution in parenchymal findings, because I think that delta is really going to tell us what pathophysiologically is happening at the level of the pulmonary lobule. And so dedicated CT imaging would be very helpful. I would ensure that this patient gets broad disseminated fungal serologies, verifying immunocompetence, so thinking about HIV, thinking about serum immunoglobulins, or is this an atypical manifestation of a common pathogen? And I would also just always re-obtain history to ensure that no clues that can be unmasked to put this atypical picture together. I often find that just sitting with patients and not going in with any agenda, but just hearing their story from start to finish again often yields the highest information to help serve them the best. And then depending on the results of this imaging and serologic evaluation, I think I would be able to generate a post-test probability of further diagnostics that would be helpful to pursue, because if those tests are still indeterminate, then the benefits would outweigh the risks of doing more invasive testing. And that would include things like endobronchial ultrasound, if there was adenopathy that was amenable to do so, bronchoscopy with BAL, and potentially a transbronchial biopsy or cryobiopsy, depending on the post-test probability that we generate. So those are my initial thoughts moving forward in this really interesting and atypical case.
Oh, it's wonderful. So many pearls there. I really love that Bayesian approach to your diagnostic reasoning process, because it's so tempting sometimes to just jump to, let's look at what the old scan was. We really have to have this question of how much is it going to change my management? Am I going to do a lung biopsy no matter what? Or if I don't see any lymphadenopathy, is this really not going to be worth it to go look and see if I can ultrasound in the mediastinum? That was great. Thank you so much.
I was just going to add that I was going to say that for me, I always talk about this as physicians, we're also human beings at best. And we really want to just do the best by our patient. And we always worry about missing something or not doing the right thing. And I think the thing that I've learned over time and that my mentors have taught me is all we can do is the best with the information that we have at the time. And so we think about what could serve a patient the best with the information that we have. And we will always do the best if we are using that information in a high yield way. So I appreciate that commentary. And that's, I think at a humanistic level, we just do the best we can with what we know at the time.
Totally. And I think that is one of the most unique aspects of medicine, is that we're almost always acting with incomplete information. We have to be making some diagnostic and treatment decisions before we have the entire picture. So really interesting. So Vish, can you share with us what the next steps ended up being? What was the relevant lab work, any imaging, and how this influenced the diagnostic process for this patient?
Absolutely. his initial labs were notable only for a mild leukocytosis and some lymphopenia, but otherwise his chemistries were unremarkable. He initially did have HIV testing that was negative. They did end up pursuing repeat sputum cultures for AFB and fungal pathogens, and as well as getting a repeat quantiferin goal, as well as broad fungal serologies. At the time when we were in this case, the testing was still negative or indeterminate for all of these. So we got repeat CT scans. So his initial CT scans showed diffuse bilateral miliary nodules that were in random distribution, more so in the lower lobes. However, when we got a repeat CT scan, which is from this admission, we saw, once again, these diffuse bilateral miliary nodules in a random distribution, but now some had developed central cavitation. Some were now more confluent, especially so in the right upper lobe. And at the basis, we saw more interlobular septal thickening that was noticed. Also, for a seizure, we had a CT scan that was performed, which revealed multiple intracranial ring-enhancing lesions with surrounding vasogenic edema in the frontal lobes, cerebellum, and pons.
Thank you, Vish. It's super helpful to kind of get the patterns and bring us to our next phase of things. Monty, what are you thinking?
Yeah, thanks for what I was going to say. I know that you alluded and Sahil alluded as well with this new onset seizure. Not surprised, but seeing and hearing Vish talk about this intracranial ring enhancing lesions, I think is an interesting finding. Probably wasn't expected when the first patient first presented, but I think this is interesting to consider. And I know we already talked about abscess formation, tuberculomas, but definitely metastasis has to be on our differentials. We think about that. But I really think this is an important opportunity. I know we like to, find radiology teaching points with everything. And I think, Vish, you mentioned some great things with how the miliary nodules from their initial appearance to their interval follow-up appearance. But one of the things that you mentioned was kind of this random distribution of nodules. And I think that's really important to think about. And something that I try to recognize is when I see this pattern of small nodules that are in random formation or nature, that really does lead me to think of some type of hematogenous spread. So the major considerations, and we've talked about some of these already, is this miliary tuberculosis? Is it the disseminated fungal infection, which I think we've all talked about, and working up serum fungal markers, trying to understand immunocompromised status, but as well as metastatic disease. And I think all of us are probably still thinking that we still have to have this on the table. That's how I tend to think of these random distribution of nodules, but I know that there's other nodular patterns that we should be thinking. And so I'm wondering if you could talk about your approach to teaching your fellows and other trainees, specifically other types of nodular patterns, perilymphatic or versus centronodular, and if you have a good schema to think about all three.
Yes, and definitely. It's one of my favorite topics to talk about, actually. And I always think about radiology and how it often adds a story to the patient's clinical picture that is not represented anywhere else. And it's true with discussing with patients. I think to get the right thing out of radiology, you have to ask the right questions. And so when I'm thinking about nodular patterns, I always ask myself 3 questions. And the first, is there a craniocaudal distribution? Because an upper lobe disease that's predominant can represent specific pathology, such as sarcoidosis, tuberculosis, an acute phase of hypersensitivity pneumonitis, respiratory bronchiolitis, and even occupational lung diseases like silicosis. Basilar findings, on the contrary, can represent other things like septic emboli, metastatic disease, aspiration-related nodularity, or even autoimmune disease. And this really speaks to the pathophysiology of the process itself, really hinging on our ventilation lung zones, which are upper lung zones, and more of our vascular mediate zones in the lungs that are the lower lung zones. The second question I ask myself, is the nodule distribution symmetric or asymmetric? Because, for example, if you have a geographic location that is just isolated to one area, perhaps it's more an infectious process, whereas something like a granulomatous disease process that's non-infectious, like sarcoid, for example, may give you a more symmetric distribution along with an upper lobe distribution. I also ask myself this question, which is number 3. is there a peripheral or central distribution? Because things that originate in the center of the chest that may be related to the hilum, I really think about a paralymphatic distribution. And I ask myself, along with this, do the nodules have a specific characteristic? Are they well-defined? Are they ill-defined? Are they calcified or are they non-calcified? Because this can give us insight into chronicity. So all kind of those non-specific cues that can add to the layer of story that we're helping to try to help this patient the best. And then I organize myself as to whether these nodules involve the pleural surfaces or not, because that's just a nice relationship between the secondary pulmonary lobule, your artery venous system, and your lymphatic system. So if they do not involve the pleural surface, then I think about central lobular nodules first. And so those spare the subpleural surfaces, they spare the fissures, and they're often evenly spaced from one another because they really respect the secondary pulmonary lobule and often related to an airway-centered process. The other thing in the non-pleural surface interface is tree and bud. And so that often has a characteristic appearance and then is associated with mucus plugging. And I'm always finding myself looking at the airways as well. Are they thickened? Is there mucus along the airways? Because often this is an acute on chronic process and can be a result of an atypical infection like non-tuberculous mycobacterium or Pseudomonas, for example. If it does involve the pleural surface, I categorize. One example would be paralymphatic, with nodules that involve the fissures that are running along the inferior aspect of the intralobular septum. Are they subpleural in nature at the periphery? And those things can include things like sarcoidosis or even thickening of the intralobular septum, which is lymphangitic spread of malignancy. And then the other pattern that falls into this category is the random or diffuse. And this often represents a systemic process that's often hematogenously spread. It allows us to really appreciate all the vasculature beds in all the aspects of the lung and the secondary inflammatory or infectious process that's causing a diffuse pattern to be represented in those spaces. So those are just my general approaches and thoughts on how I categorize nodularity.
Oh, I love that. And I love the respect into the secondary pulmonary lobule. I don't think this is something we think about that much. It's always a picture I draw up and that we've shared on Pulm Peeps for how to interpret a CT scan, but really whether or not it's violating or respecting those borders is a helpful paradigm for this. And then I think we should also mention, it'll be less in our wheelhouse, but something as intensivists, generalists that we'll also think about is that ring-enhancing CNS lesions have their own pattern and differential that can help us. And certainly, we can think about the things that we commonly mention. We've already talked about a lot of these, but septic emboli, abscesses, nocardia, fungal infections, parasitic infections, malignancy, vasculitis, sarcoid. But I would also get on the phone with my neuroradiologist and say, what does this pattern or distribution or size or the different locations mean anything to you? Does it raise a differential for any of these to have that more informed pattern recognition for the CNS imaging to help inform our decisions as well? This is a really interesting case. At this point, it sounds like this patient's getting worse, had presumed TB. We definitely have confirmed worsening of pulmonary process based on the progression of CT scans, and then now clearly a CNS process along with it. So it seems like we're leading towards needing to get some more tissue from somewhere to help confirm a diagnosis. So Vish, what happened? What did you guys decide? What was the next step for the patient, and how did it turn out?
As the old adage goes, tissue is indeed the issue. At this point, there was still a reasonable suspicion for infection, as well as a growing concern for malignancy as well. So after reviewing the imaging, it was determined that the lungs offered the least invasive route and probably the highest yield site for sampling. At this point, the patient was clinically stable, required only minimally oxygen, and he was likely to tolerate bronchoscopy pretty well. So our initial plan was to perform ABL, an EBS with TBNA of one large mediastinal lymph nodes that we saw on the CT, and do a transbronchial biopsy. An additional wrinkle here is to consider whether to pursue a forceps biopsy or cryobiopsy. I'm interested in IP, and this is something that's been rapidly expanding. And there are some case theories and some studies that would suggest that in this case, when the suspicion for malignancy is high, the cryobiopsy generally offers a higher diagnostic yield. It gives you larger tissue samples. And more importantly, it also gives you better adequacy for molecular testing, which will be more and more important as we have all these new therapies that are coming down the line. And it also has the added benefit of avoiding the crush artifact. Although all this comes at the slight cost of higher complications in terms of slightly higher rates of bleeding in pneumothorax. So, interestingly enough, Dr. Pandya happened to be the proceduralist for the case. So, initially, the first part of the case was the EBS TBNA. So in the room, we had rapid on-site cytology, or ROSE. And when we initially gave them the sample, the first thing that they told us is that this looked very consistent or very concerning for malignancy. So what we did is we obtained initial samples in the room, and after confirming that sufficient material had been obtained for molecular testing, we didn't really end up taking more biopsies.
I'm going to stop you there, Vishwajit. I have a couple follow-up questions, if that's okay, because this is so interesting. So my first one is, because this comes up from Pulm Peeps listeners a lot about choosing the right procedure. And this seems like the procedure that this patient was going to be headed for that I probably would have chosen too. But the question that comes up often is people say, what about a VATS? He's young. He has this diffuse process. What factors go into deciding about that, of choosing less invasive but biopsy this way, or thinking about getting our thoracic surgery colleagues involved to think about a VATS?
So generally, you could make an argument in good faith that this gentleman was relatively healthy and would tolerate a procedure such as a VATS very well. Additionally, if there's a high pretest probability or suspicion for something like interstitial lung disease or a diffuse parenchymal process such as that, I think a VATS would definitely provide a much better specimen. But there are two things in this case that led us towards maybe pursuing a cryobiopsy in this case as well. One was the patient preference. He was somebody that would have appreciated a less invasive approach. And when we presented him with options, this is what he ended up leaning towards. And the second is, in this case, it looks like we were dealing with a diffuse parenchymal process. And while, once again, you could say that when IOD could have been on the differential, the suspicion for malignancy was higher. And when you have a diffuse process like this, the diagnostic yield is fairly reasonable from a cryobiopsy alone, somewhere from 70 to 80% based on whichever trial that you read. I thought it was very reasonable to pursue a cryobiopsy in this case and would probably provide a good answer.
Yeah, I totally agree. And also it seems like maybe like the overall architecture is less of the question and then some of just getting a good sample. Yeah, Sahil.
Yeah, and the other thing I was going to say, the other nice part about doing the endobronchial ultrasound is I think as malignancy was atypical but rising in terms of pretest probability, I think our desire to stage the mediastinum also in doing this procedure was also one of our utmost priorities. And so it balanced kind of risk benefit for the patient, but also having the highest stage for a potential malignancy to offer the dedicated treatment in that moment was another reason we were thinking about this.
Yeah, that's wonderful. And then I was going to ask you as one more follow-up question, because I don't think we have touched on this topic in Pulm Peeps. ROSE, so helpful, so interesting. How does it change you as the proceduralist in the room to have the rapid onsite there? What technique are you changing? How does it change the way you're going to proceed with the procedure like it did in this case?
Absolutely. So Vish, you and I can tag team this. I'll start. What I really like about ROSE is overall, I think there is a lot of verbal feedback in terms of what material we're getting. Is it adequate material? And is there any sort of diagnostic certainty in the room that would dictate how many samples that we need to get? And then also, do we need to change our technique from certain times? So oftentimes in the room, I'm finding myself saying I'm seeing that there's a little amount of material or there's necrotic tissue. Perhaps endoscopically, I can see that there's a different area of the lymph node that I may be able to attack so that I'm not getting that type of material. And then also plus or minus the utility of suction, depending on the amount of material that you're getting. And then also, I think oftentimes we find ourselves, we want to provide the highest stage and make sure that we're completely staging in the procedure. But oftentimes, I'm sure we've all been there as proceduralists where we're taking samples, we've done it, we know we're in the node, but we're getting nothing. And so then in that way, we can make sure that we've done our due diligence, but then also think about pivoting to alternate sites that can give us similar answers, but also we're not just hopelessly doing the same thing over for the long period of time, because then the patient is exposed to longer amounts of anesthesia, further risk of complications. So it allows us to just maintain a mental model of staying on track, our yield in the moment, and then also real-time communication about what we're receiving is actually adequate for the patient. Vish, do you agree? Anything else that you would add on that?
The only thing I would add is based on the CT, there were some of the areas, some of these nodules that we were intending to sample did look necrotic. What can often happen, and I think you alluded to this, is that you can get samples, but it might be from the necrotic area. Now, having somebody that will give you real-time feedback as in, doesn't look like a great sample, this all looks like necrotic material, can be very invaluable to prevent further from future procedures. So I think in some of those cases, it can actually be very helpful and valuable.
Yeah. Thank you guys so much. I think that's really valuable insight for all of us, especially people who may be less familiar with the EBIS process. So what'd you find? What came up?
So on the pathology report, they saw that there were tumor cells that are positive for TTF1, CK7, and napsin, which is probably most consistent with the diagnosis of miliary adenocarcinoma. So the patient had additional molecular testing, which showed the presence of a fusion gene. And based on that, he was started on a targeted therapy called crizotinib, which is a tyrosine kinase inhibitor. Once again, the images that this patient had are quite impressive, and I'd encourage everyone to look at the images after treatment. And in fact, what was diffuse miliary disease seems to have almost disappeared with treatment of his targeted treatment that is directed towards his therapy. It is a very nice set of images after all, and a very good outcome for the patient overall.
That's great to hear. We'll definitely share the images and make sure that people can see it on our website. Maybe we'll even lead with those. And such an interesting, maybe unexpected, 27 years old, I would certainly have this low end differential, but great that we got there and got him to a good outcome. This is a really amazing case. Thank you both so much for coming on. One thing that Monty and I love about this series is not hearing great cases, meeting fellows who are on the front lines taking care of these patients, and then also just spreading this network of people interested in medical education and sharing insights. And everybody just always has great pearls for us. So we would love for you guys to share a little bit more about KU and what you like about training there. And I think you're in interview season right now. So what do you want your people who are interviewing to know about your time there? Vish, I guess we can start with you.
Well, I know it's a little cliche, but my favorite part of the program is generally my co-fellows. They really do make the journey of fellowship so much more enjoyable, and it's nice to learn from them. The other thing I really like about KU is about how collegial the atmosphere is. I remember texting Dr. Pandya maybe at 7 or 8 at night about a new trial that had come out and what were his thoughts about it. It's a great atmosphere to learn and thrive in, and it's something that I've really enjoyed for the past couple of years.
Yeah, I'll piggyback off on that. Yeah, I want to thank you guys all for the opportunity to speak today. It was a fun and exciting time to chat about these things. Here at KU, we're really proud of our fellowship program because I think, like Vish said, it really prioritizes the fellow's voice to be the strongest. We really hinge on real-time and dynamic feedback. We always say that if we are not changing, then we are behind, and it is so fun to be innovative with our fellows. We leverage really being creative, being innovative, and really creating an environment where challenging the status quo is welcome and celebrated. And I think even more than that, we value all of our fellows as human beings and clinicians. And so we really want to know what they're doing at work, what they're doing outside of work, because who they are as a whole is so important to us. And we really focus on growth because all of our fellows leave feeling confident and competent and really being leaders in pulmonary and critical care. So we love about KU.
Amazing.
That's awesome. That's so great to hear. And definitely, Vish, not cliche, right? I was telling a trainee the other day, I was like, the work that we do is really hard. The training that you go through is really hard. And pulmonary and critical care medicine. So having that supportive network around you is so important. And that's from co-fellows to fellowship leadership. And just being with y'all for the last 20 minutes, it really seems that such a great and supportive and collaborative environment. So excited that you have that and excited for y'all to be able to share that with us today. This was really a fantastic case. And I think some really nice points that we got to share today and highlight. I know Dave and I always end the episode with a take-home point. So I think for mine today, I really liked how you went over the distribution of pulmonary nodules and really to think about that. And we talked about the random distribution, the perilymphatic, as well as the central distribution. So thanks for sharing your approach and schema for that. Murph, what about you? What are you taking away from today's case?
Oh, I had so many. I read with the nodules. I also thought that thinking about EBIS in its multiple different facets of both being able to obtain tissue, but actually doing a visual inspection and being able to try to stage things in the highest level possible. And then also I appreciated Vish bringing up the fact that when thinking about the right procedure, a lot of this has to do with what's going to get you the best answer, but then having that conversation with the patient and laying out the options and what the positive benefits are going to be, because you can't really get to the next stage without going through that. Vish, any takeaway points you had from this case?
My takeaway point from this was really how much of a great outcome this was. We've all had that sense of dread where we see something on imaging that might portend a really poor prognosis. But it's really remarkable to me that this patient did so well after having imaging findings that looked so terrible, if I'm being frank. So it really speaks to the progress in medicine that we've seen and gives meaning to all the things that we do inside the hospital and the clinic every day. So it gives me a little bit more energy to go back and do that again. So that's my takeaway point from this.
Awesome. And I think I would echo that 100%. And I think for me, a big takeaway from this case, being part of it and seeing it come through, evolve over time, is just the importance of keeping the patient at the center. I think the patient came in with a fair amount of fear and was worried, and it would have been so ideal for us to have tissue in the beginning and be able to expedite the process. But I think the patient wasn't ready, and I think that's okay. And I think we were able to gather information. And so I think the patient really appreciated that patient approach to allowing us to justify the risks and benefits of procedural intervention. And I think it's easy to forget that part, that patients do have a lot of fear with all the things that we do in medicine, and meeting them where they are and allowing them to partake in their decision making really allows for the best outcome. So that was a big takeaway for me in this case.
Absolutely. Thank you both so much again for coming on the show. Thank you all for listening. Make sure to join us in a couple of weeks for our next episode. This episode was edited and produced by myself and Christina Montemayor. The music's original music by Eric Rogers, and we will see you next time.